Thank you for all our speakers. That was really interesting and different topic. I think Dr. Yuri is joining us now also for any question. Anybody has a question? Yes.
Thank you all. Excellent presentation. My question to Dr. Hussein. Dr. Hussein?
Hussein Mir or Hussein?
Mir. Now, in terms of thyroid scan, what is the difference between technetium and iodine 123 in terms of specificity, sensitivity, and technical things? And my second question to you, what you prefer in terms of an example, Graves' disease treatment with radioactive iodine? Do you prefer the calculated dose or the fixed dose?
Yes, this one. No, before. Yeah. No.
Okay, thank you. So your first question is the difference between technetium and iodine. Iodine is organified inside the gland, so it gives you physiological information more than technetium. Technetium is a pretechnetate and cheap, available. You don't need cyclotron or strong nuclear medicine background. Any hospital can use that technique if they have gamma camera. So technically, technetium pretechnate is very easy, and anatomical interpretation is straightforward, while for iodine 123 is quite expensive, and it gives you more physiological information. So if you are scanning thyroid for Graves' disease, for example, as you said, both can answer the question, both can show you, but if you have a lesion, you want to characterize that lesion, iodine 123 is more informative. Of course, iodine 131 is out of when you are talking about diagnostic scan. Yeah. Regarding your second question, if you are talking about endocrine cases, non-cancer, yes, we can go for fixed dose. As far as the dose is below 29, some hospitals, they are using this protocol. But if you are talking about cancer, no. You have to evaluate. You have to tell if there is size of the lesion is important, because you want to kill the thyroid tissue, but you want to protect the adjacent tissue also. So giving extra unnecessary dose is not wise, and giving less dose is also not a good therapy outcome you will get. So if there is lymph node metastasis, you have to raise your dose. If there is, for example, lung metastasis, you have to raise the dose, and at the same time be careful about the lung tissue. You have to do CT scan and check if the patient has lung fibrosis or not. So going for fixed dose, fixed dose will not differentiate between smoker patient and non-smoker patient. For a smoker patient, you have to reduce the dose. Otherwise, he will get unnecessary fibrosis because he has weak lung parenchyma. For cancer, no. I will not recommend fixed doses.
I have a question for Dr. Yuri. Hello, Dr. Yuri. Thank you for joining us from the United States. I hope Pittsburgh is not too cold like here. My question to you is, there is no special collection for ThyroSec. You just need the old slides, and they send it to you, and you'll be able to do it. Can you tell me how do you do that? I'm just puzzled how you can have a slide without special collection and be able to do the sequencing.
Right. Well, thank you first of all, for asking me this good question. So if we look back 10, 15, 20 years ago, you're absolutely right. For example, for RNA, we would not be able to perform it using fixed smears. We needed just freshly collected tissue to do it. But over the last 10 years, we moved to this new technology, which is called next generation sequencing, which amplifies very, very short pieces of DNA or RNA. And using this new technology, we overcame the need for freezing tissue. I can tell you in a way it's the same technologies that, look at the mummies or some organic material from thousands of years ago and still can extract sort of sequence DNA. In a general way, of course, on a different level, that's what we use. So using next generation sequencing, we now can reliably test for mutations and gene fusions using fixed material. And that's why we can use routinely prepared cytology smears as old as 10 years old. We can still remove the cover slip, scrape cells, and test them for all genetic alterations.
That's very impressive. Thank you.
Yes, Dr. Hussein has a question.
I have a question to you, Yuri, also. Once we get negative result from Tharosec or Afirma, let's say on a floss nodule, that's, let's say, 2 centimeter nodule, what would be your advice for the clinician on the follow-up of those lesions? Since something can happen in the future for those nodules, or are you confident to say that those patients do not need follow-up?
This is an excellent question and very common question when we discuss such clinical situations. So we generally recommend follow-up for these patients in a similar way how American Thyroid Association suggests follow-up for patients with cytologically benign nodules, which is based on the ultrasonographic appearance. If ultrasonographic appearance is worrisome, it's a sort of high concern. It's a high, by ATA, or it's a TIRAS 4 or 5. Generally, these patients would need to be seen again in 6 months, in a year, just to perform an ultrasound to look if nodule grew or not, and they need to be followed closer, absolutely. If ultrasound is not really worrisome, it's more like sort of on a lower risk, then these patients can be seen less often, let's say in a year or 2 years. And if nodule didn't grow and there is no change in ultrasonographic appearance, then probably follow-up can be less common. But to your point, absolutely, these patients still need to stay, at least for foreseen future, under medical attention, because none of the test is 100% accurate, the same like even cytology, and still there is a remaining risk of cancer, small but remaining on these nodules. So other clinical parameters, including ultrasounds, are very important in following these patients.
I have a question to Dr. Hussein Mir. Thank you. Very nice talk and review for all of us. I have to tell you that we have more than 1,700 people who are watching us virtually, but not attending here. We have a small number here, but virtually we have 1,700 this morning. Now it's maybe higher. The question to you is, with the parathyroid scan, I have lots of cases, and I've seen lots of colleagues complaining about this. We get negative parathyroid scan, but clinically it's 100% hyperthyroidism. And the surgeon will refuse to go in because he needs to localize. It's not like the old time when the surgeon does not have to do anything. They go open and they look for the adenoma. Most of the surgeons will refuse, and we are 100% sure they do have that. Sometimes we use MRI, still MRI, we cannot be able to localize it. But clinically, they are hyperparathyroid. Now, I know there's negative cases that we cannot really get clear adenoma in the parathyroid. But what's your take on that? What should we do?
80% of the cases are adenoma. You have 4 parathyroid glands. Size is not an issue. If you are, depending on radiology modality, CT or MRI may fail you and show you the biggest parathyroid gland as the pathological one, which is not accurate. System maybe will show you which one is hyperactive and which one is to be removed. I don't know, you said the radiology is negative. Are you using MRI technique, ultrasound, or nuclear medicine?
Both. But clinically, it's 100%
Yeah, but nuclear medicines, the sensitivity is more than 95%. It's very, very unusual that you have adenoma and it is negative by parathyroid.
See, in endocrinology, the diagnosis of hyperparathyroidism is biochemical. It's not really radiological at all. And we do it only for localization. It's not for diagnosis.
Yes, exactly.
Even the best surgeon in Bahrain, unfortunately, they returned the patient and said, you don't have it. And they have it. And they have it for years, and they have clear manifestation. And yet they refuse to do the surgery for them.
No, you have to confirm which gland is affected. He will not remove the 4 glands.
But they explore. The surgeons, the good surgeons, endocrine surgeons, they open up and they explore. And they look at all the parathyroid glands. Unless they're ectopic, then we have a different story.
Yeah.
I think you should find an old-fashioned surgeon, endocrine surgeon, to go and explore, as you mentioned. Our institute, they're using like 3D or 4D, something CT, to try to localize those tumors. And also they're using specific PET scan. I don't know whether it's DOPA or something else. Yeah, also to localize. But again, as you mentioned, sometimes they all come negative.
I have a last question to Dr. Yuri. How much would it cost for the ThyroSec test? Approximately.
You're asking a very difficult question.
Yes.
I mean, as you know, the cost is different in different countries. If I understand correctly, cost of thyroidectomy in the United States is about 5 to 10 times higher, for example, than in Europe. So it's all very, it's all really different. I can tell you, we do have a distributor of our test in your region, yes. But really it will be up to them to really discuss the cost to the patient for this test. I'm sorry, but I cannot really say one number for this test.
Okay, thank you.
I have a question, Dr. Hussein Raif. Excellent presentation, Hussein. MashaAllah, the data that you brought and the experience that you have in King Faisal is amazing. We don't have those cases. I don't think we're picking them up. I think they are there, but we are not picking them up. One observation we had is organin A is sometimes high in patients who are taking GLP-1s, Saxenda per se. And I have looked at several cases where they have elevated organin A. I don't know if we had some experience with this.
Classically, it's the PPI that raised the chromogranin, and can raise it quite a bit, a few folds higher than the upper normal. And I have a number of examples where we stopped the PPI and the chromogranin comes back to normal. GLP-1, I'm not sure whether, what is its effect of
C-cell effect, maybe?
Yeah.
See, because we are worried about C-cell hyperplasia. True. Maybe it does have an effect on that.
Right. If your question about, in a human, humans don't have so much GLP-1 receptor in the thyroid. So theoretically, the effect should be minimal, if anything. But I'm not sure. If you have cases, it's really nice to look at. Yeah.
And I would like to thank you all for this great talking, Dr. Hussein, Mir, Dr. Hussein Raif, and Dr. Yuri. Thank you very much for joining us, and it was an excellent talk, all of you. Thank you very much.
Thank you. Bye-bye.